So there is a research paper which was just published very recently. I think it was about a month and a half, 2 months ago. So this research paper used AI to leverage a predictive model which categorized patients into, I think, 5 different or 6 different categories for their prognosis based on a bunch of different variables that they first analyzed and then built this model and then retested on the data set that they had. And then they applied it prospectively to see if it was actually predictive or not. The interesting thing with this model is it's designed to tell you how many euploid embryos you will make over 3 rounds of IVF. So you plug in your age, your weight as a woman, your height, your AMH, and your antral follicle count. And it's an app. It's available for free on Apple. Okay? So the neat thing about the data is not so much the positive outcomes, because if you were in the very good category, you had a really high chance of having euploid embryos. But the neat thing is that if you are in the very poor category, you have a 0% chance of getting a euploid embryo over 3 rounds of IVF from their data set. Now, people can criticize the study if they like, but it's a helpful tool in guiding people as to what expectation to have. And since my part was expectations, it's something that we can use to kind of help guide you, and you don't even need us. It's readily available there.
Yeah, I was hoping to put us on the hot seat up here, because I think it leads to an interesting question with these new tools coming out, the data that's coming out, is what's the relationship that we would have as notional experts in the field versus AI? Like, where are we going with this? If you're a patient now, how do you handle distance between what you might find in your own research or what ChatGPT or Grok tells you and what your doctor's sitting in front of you? I'm happy to start, but I'm putting us all 3 on the spot here. Do you have a hot take on this?
Pratty?
I mean, I think this is where the art of medicine takes place, right? The data is the data, but is every single patient in this room generalizable to the data? So I was just thinking as you were talking about this paper that I too read, you know, if you put your numbers into this calculator, you're 42 years old and it says you have a 0% chance of making embryos in 3 cycles. Well, I would flip the narrative a little bit, because there was a study published, not in the last couple of months, but in the last couple of years, I would say, in FNS, that showed that women over 40 who produce 0 euploid embryos in 1 IVF cycle have a 25% chance of producing euploid embryos in their next cycle, because every cohort of eggs is different. Your second IVF, everyone learns. The patient learns, the body learns, the physician learns, and we change the protocol. So it's not all mechanical, and it's a combination of what the doctor feels your best next treatment steps are, what you feel your next treatment steps are, and the data.
Yeah, so listen, this is one study, it's one algorithm. I agree completely. Dr. Google is our collective nightmare. I think we can all admit to that. And it's difficult to be able to address every single question that patients have from everything that they've read, because we have to know the research, we have to analyze the studies, you have to do something called critical evaluation. So I think these tools are up and coming. I don't think that we're there at the point where we can say definitively your chance is 0, but we have to be prepared to address it when you show up and say, hey, I tried this and it says my chance is 0, what do you think? So I agree. I mean, part of this is us knowing our skill, our program, our lab, which is going to differ from the lab that ran this test. And part of it is going to be, you know, you saying, well, answer why you're different, how you're different, what's your experience.
I think, so thank you for those answers and for leaning into this space. It's just interesting. It's just such an interesting time. And what we previously called the art of medicine is also now increasingly becoming digital. You know, that AI is going to know you, some aspects of you, far better than we're going to in the hour or 2 hours or 5 hours that we get to know you. That AI can really spend some time and really understand your hopes and dreams and needs, and can present data. So what's the value, in my opinion, what's the value that having a trusted clinician going forward? I think there's 2 things. I think there will remain distance between the data and real life. So as new tests come on board, just before the data collection is available to AI, we might start to have feelings about it. There can be some side value there. But truly, I think the greatest value is the willingness to take responsibility with you for that outcome. It's the greatest challenge that we've all of us had with AI, is it always tells you you're awesome, your ideas are fantastic, and lean in and go for it. Cool, but with who? And who's got your back if it doesn't go the way it was meant to? So I think increasingly, we're all in this journey together. As data gets more and more ubiquitous for all of us, it's about finding a partner to work on these things together.
Yeah, I agree. I think the data is there. It's important to arrive at your appointments informed, but every physician on this panel indicated towards this, but it's equally, if not more important, to find somebody that you can be transparent and have trust in, to ask all those questions, sift through the difference between the data and the physical findings, and then get to a pathway.
Can I just add one quick thing? All of us want you to succeed, okay? Nobody here wants you to not succeed. Everybody wants you to try once and be successful and come back and have more babies. So we are 100% vested in looking for whatever tools there are to improve your chances of success. And unfortunately, it takes a while to figure out what those tools are. There are tests, even I reviewed here, which came out and initially sounded so promising and then subsequently showed that they were absolutely useless. So we very much want things to be useful to us so that we can help you, but it takes time in many cases to figure out, are these really helpful tests, really helpful adjunct treatments? And some people will be skeptical appropriately at the beginning. Other people will jump in both feet saying, hey, it's worth a try. And it often takes years before we actually are able to say, yes, this works, or no, it doesn't.
Yes.
I want to ask what factors should we be considering when choosing a fertility clinic, and what would differentiate one clinic from another?
I can start if that's okay. I think that it is important for you to choose based on various factors. One, let's be realistic. You're going to be in that clinic many times. So it's important to pick a clinic that's going to be accessible for you, whether that's near your workplace or near your home, if you're working from home, because infertility is already a very stressful process. We know it can take multiple cycles, so probably being somewhere close to a place you can access makes the most sense. I think being with a doctor who supports your ideas and your goals, and you feel like you have a relationship with them, you can access them, you can speak to them. And when I say you can speak to them, it's them and their care team, right? Because a lot of the connection that you'll have with the fertility clinic is, when is my next appointment? I need my drug dose for today. I need to make this appointment. So I can tell you in my clinic, my secretary, Justin, has been with me for, I won't say the number of years to date myself, but she's been with me since day one of my practice. And so she knows my practice inside out, and so she is the touch point, the first touch point for the patients, and the patients trust her. So you want to be able to feel comfortable with your clinical care team. Success rates are also important. There's a lot of competition in the GTA and even in Canada. All of the labs that we work at are incredibly reputable, but you want to be at a clinic that has high success rates. Now, everyone says they have high success rates. The data isn't published. This is another whole conversation that I would love to get into one day because I have strong feelings about it. But, you do know, or you can tell which clinic has higher success rates. They've been around for a while. The experience of your physician matters. I think patient reviews are very important. These are patient reviews of patients who've actually been to the clinic, so I think what the patient states is very important. So many of my patients have said, and I'm sure it's the same for my distinguished colleagues, I wish I came to you first instead of making the rounds to 3 or 4 different clinics and 3 or 4 different doctors. So speak to your friends who've gone through fertility treatment, look at the reviews, people are more open about having the conversations now, which is a great thing.
Okay, that was an awesome answer. Dr. Sharma, that was totally comprehensive. and I agreed with like 90% of it, I'm gonna, no, it's like a really good answer. But I will say that I think in increasingly modern practices, so much of it's virtual now. I think that the physical location matters less now than it did a year or 3 ago. That's a great thing, particularly for people who live outside of the GTA. I think trust in your clinician, as you said, critical, because they're the one who's going to set the path with you. It's a shared experience. You're going down it together. You've got to trust that person and in the team. Hopefully, you've got a key person that you know you can always access. It's probably not going to be the physician all the time. And anyways, the physician isn't executing on a lot of what's happening. Like, you need someone who's like, you know that they actually know how the pen works. You know that they know what the office hours are. Try pressing your doctor on those details. It might be a little vague. So like, it's at least one other person other than your clinician. And then I'm going to validate the greatest challenge of all is in the labs. You know, it's behind the black box, right? There is no standardized way in Canada for revealing those success rates. Labs are different, and I'm just acknowledging that truth. And I have yet to discover a good proxy for patients to have that deeper sense. So I'll leave it with this. Yeah, we're reduced down to reviews, and they're tricky. They're tricky. You know, we don't actually, so to this point, we've not been asking our patients for reviews, which is difficult. On the one hand, you get some super weird variant of people who, like a tiny fraction of our patients are actually doing this. On the other hand, if we ask, it's problematic, because then we're asking people to expose their name in the midst of treatment with us. I don't know. I actually really struggle with it. Yeah.
So I really don't have a ton to offer. I kind of agree with both of you on that. Geography I don't think is critical. Having said that, I'm probably very biased because I am not in the GTA. But you know, COVID, doing virtual, as Tom mentioned, all of us have relatively international practices. A lot of my practice is from the US, from the UK, from Australia. I mean, geography is not a huge issue. My thing I tell patients when they ask me is, I think your single greatest asset is the relationship you have with your doctor. Because not every journey is going to be successful. Hopefully most are. But you want a relationship where you come out of this process feeling validated, educated, informed, you know, that you got to make your decisions your way and that you had a team that worked with you. If you feel like you got shoved into the IVF grinder and came out, you know, devastated with nothing to show for it except for a huge financial loss, I think that's just devastating. You know, even when you're successful, there are lots of studies that show that you carry the trauma of the experience with you. So you want a team that's going to help you through that journey, and that your comfort level is kind of paramount.
I'm going to add, because I got shot down on the virtual piece by these two. You do have to have your retrieval in one place if you don't want that to be 3 hours away. But I will also say, not that any of us on this panel are a fan of patients who doctor shop, but it's your life. You can have 3 virtual consults with each and every one of us. We'll talk to you for 45 minutes and you can get a feel for what our opinion is. And that is A-okay. I always tell my patients, you know, I'm happy if you think that it's a time for you to take a second opinion. I'm happy if you bring that second opinion back to me and I'll consider all of that. Or if that's a better place for you, then that makes sense. I mean, fortunately it doesn't happen a whole lot, but you know, you're autonomous. So have those 3 consults, meet with all of us, see who makes sense for you.
Agree. Yeah, 100%. Or help me convince these 2 to open up a clinic with me, and then you can get all 3 of us at once. That would be great too.
I'm gonna move that comment from
Strike that from the record.
Yes, please, because there's not enough time for that. Any other questions in the audience? I'm gonna ask one that was predetermined before, and some of them have gotten answered. But this one was specific for Dr. Sharma and on the topic that you spoke of. How do you counsel patients on when it's time to change course or escalate their treatment plan to something different?
Great question. So I tend to see patients after they failed 2 to 3 IUIs to discuss what the next steps are, or after a failed IVF, or after 2 failed transfers. I think there always has to be a touch point, or you just keep going and going. So obviously this decision is based on many factors. In general, and again I'll say very much in general, I think if you are a patient who is under 35, a woman who's under 35, and you've tried 3 to 4 IUI cycles with either oral medications or a combination of oral injectable medications, open tubes and normal sperm, that is a good touch point to talk about moving on to the next step, which is IVF. Again, it's not absolute, but after 3 to 4 cycles of IUI, your success rate, unless we find something new, is probably not going to go up much, and it's time to consider IVF. Certainly, if you did your IUIs and the sperm was borderline or low, or there was only 1 tube that was open, but we decided to try IUI just in case it would work for the other tube, again, those are reasons to move the needle and move to IVF. If your age is over 35, you do want more than 1 child. The tougher piece I find, and this is a tough one because finance is also playing a role when it comes to moving from IUI to IVF, but the tougher piece, and we're going to talk a lot about this in today's conversation, is when do I stop doing IVF and move on to egg donation, surrogacy, or sperm donation? And this is a very difficult one because there is a lot of anxiety associated with that decision. So I do spend a lot of time with my patients who, let's say, are 43, 44 years old and have failed multiple cycles with no deployed embryos with their own eggs, higher FSH levels, lower ADH levels, and they want to keep trying with their own eggs rather than moving to egg donation. And this is a tricky one. I think, again, it comes back to the relationship you build with the patient. The conversation about, okay, this is the hardest point you'll be at, but I tell my patients in that situation all the time, once you get past that hump and you decide to move on to donor eggs, and everything is positive. Wow, you've got a lot of eggs, you have a lot of embryos, there's a lot of normal ones in the first embryo transfer hopefully takes, then most people are not looking back thinking, God, I did donor eggs and I wish I didn't. So this conversation is really important, it's tricky, it's emotional. Obviously we take the data into play, but what you want, what the physician thinks is right with you, having those conversations. I meet with patients multiple times to decide this. I have patients who have multiple follow-ups with me when they're going from IUI to IVF or IVF to egg donation or egg donation to surrogacy. So this is why we love what we do. We love having these conversations. We want it to work for you in the right way at the right time.
Thank you. There is a third-party panel at this event as well for those of you who want to have a little bit more information about that pathway. Dr. Moore? There was a question, and I know this kind of went backwards because this is a little bit more in the beginning stages of this talk. But the question was, what is the actual way to determine or define if you are considered infertility?
Oh, there's a, if you go to the literature, people would say 6 months or 12 months. In my opinion, those are old definitions that don't have relevance any longer. I think that this is about family planning, family building. So I think it's up to the patient to decide what's right for them.
So there was a time when family physicians or nurse practitioners would not send a referral until they were trying on their own for 2 years. What is the more current practice that they can advocate for themselves?
I think people should have the opportunity to advocate for themselves from before they even necessarily need to define themselves as a fertility patient. I think that women should have the opportunity to test their ovarian reserve at an age that's appropriate for them so they can start to think about family planning and family building sometime under the age of 35. I just think it's all about patient autonomy and reproductive rights. So that's what I think.
Yeah. Patient your own advocate is the biggest piece there.
Great answer.
Dr. McDurdy, what is the most important thing patients should understand about success rates? What do they actually mean?
Well, your success can be defined depending on what the clinic is choosing to report, right? So there's separate things we have: positive beta HCG, clinical pregnancy, which means we see a fetal heartbeat on ultrasound, live birth, miscarriage rate. So there's different elements to what success could be defined as. And again, it's important for you to know the holy grail, obviously live birth, right? So there's no question that there is a decrement, as Dr. Sharma mentioned earlier, at each stage of the process, right? You have 20 eggs, maybe only 18 were retrieved or 17 were retrieved. Maybe only 14 of them fertilize. And then whatever percentage make it to blastocyst, you get lucky and you have 10 that make it to blastocyst, or you're not so lucky because the sperm quality is bad and only 5 make it to blastocyst. And then based on age, you got to see how many are genetically normal, and then you're going on to what the success is that each of those is going to become a baby. So there's this like slope where you're losing a little bit at every stage of the process. And so you need to know from the standpoint of your calculations, when the clinic tells you our success rate is 80%, is that positive beta? Is that live birth? Like 80% what? Is that per embryo transfer? And so it's just important that everyone be reporting kind of the same thing, but it's hard to get this standardized. And so you need to ask, when they say this is your success rate, ask them what are they referring to.
Yeah, and that's the reason why I brought that up, because you made that exact comment about the success rates. It's important to have a little bit of information about the clinics. Some clinics might not even be measuring the same targets and endpoints, so you're not comparing apples to apples. If there are no further questions, no, it looks like we're good. I want to say thank you very much to everybody who joined to listen in. Hope that this gives you a little bit of a clearer picture of what to expect medically and how to ask the right questions as we navigate your fertility journey. If you'd like to follow up with any of the speakers or learn more, please feel free to go find them at their booths on the trade show floor, and there's a map of where everybody is, and you can have some moments with them to possibly book a consultation once they return back to their offices. Enjoy the rest of the day.